My name is Evan Quirke and I am an SHO in anaesthesia at the Mater Hospital Dublin. Today I will present our audit of the perioperative management of patients taking GLP-1 receptor agonists, comparing our current practice with current international guidelines. GLP-1 receptor agonists are now prescribed increasingly for both type 2 diabetes and weight management. These medications delay gastric emptying, raising concerns regarding residual gastric contents and increasing risk of aspiration during general anaesthesia. However, recommendations have evolved considerably in recent years, with newer guidelines favouring risk stratification rather than routinely withholding treatment. We therefore performed a retrospective audit of all patients attending our pre-op assessment clinic between January and April 2026 who were receiving a GLP-1 receptor agonist. 50 patients were identified and our practice was compared against current guidance from the American Society of Anaesthesiologists, the European Society of Anaesthesiology and Intensive Care, the Association of Anaesthetists Great Britain and Ireland, and the Australian and New Zealand College of Anaesthetists. Most patients were receiving weekly preparations, predominantly semaglutide, and approximately 2/3 were prescribed treatment for weight loss. 5% of all patients attending the clinic were taking a GLP-1 receptor agonist, demonstrating how commonly these medications are now encountered in routine practice. Our audit showed that local practice largely reflected the older, hold-based approach. 62% of patients were advised to stop their medication for 1 week before surgery, regardless of indication or individual risk factors, and this contrasts with the more recent AAGBI and Australian guidance, which recommends continuing therapy in most patients while performing structured risk stratification. Documentation was another major finding, with 60% of patients having no documented assessment of gastrointestinal symptoms, despite symptoms being central to risk assessment in every international guideline. Similarly, only around 30% had documentation regarding how long they had been established on treatment, limiting our ability to identify patients at highest risk of aspiration, as after approximately 12 weeks on a stable dose, the body develops partial tachyphylaxis to the delayed gastric emptying effect. No patient received dietary modification advice before surgery, despite this being recommended in more recent European and Australian guidance. Likewise, all patients followed standard fasting instructions without modification. And finally, gastric ultrasound, now recommended by all 4 guideline bodies as an important adjunct for risk stratification, was not documented in any case, while aspiration risk was specifically discussed with only 8% of patients. In conclusion, our audit demonstrates that our current practice has not kept pace with evolving international guidance. The greatest opportunities for improvement are consistent documentation of treatment duration and gastrointestinal symptoms, introducing structured risk stratification, providing dietary advice where appropriate, and developing a local gastric ultrasound pathway. We are now using these findings to develop a standardised institutional guideline with plans to re-audit following implementation. Thank you for listening.